Good evening. This is John Bailey. This is People to be Heard, the program where people who have something to say have their say. Tonight, you've got Dr. Mona Kennedy, family medicine physician at York-Presbyterian Hospital and Lawrence Hospital, part of the Westchester Medical Group in White Plains, New York, USA. And she's also a new resident of White Plains. Welcome. Nice short commute now, right?
Much better.
Exactly. Well, thank you for joining us and coming to the program.
Thank you for having me.
I was very fascinated by your comments at the Food Bank Hidden Hunger News Conference in August last summer. You're shown here with the panel, and that's you on the next slide at the panel. And could you tell us what has been the result of that hidden hunger effort to publicize hunger in Westchester, and how is it going forward to perhaps alleviate this problem?
So thank you for attending the Food Bank Conference News, and if you recall, we had discussed food insecurity.
Right.
So first, to define what food insecurity is, it is not having reliable access to affordable and nutritious food in order for a family to provide. So the key word there is nutritious food. So you can have access to low-cost foods, but they may not be beneficial for your health. So our job that we need to do as physicians and as a community is to be able to have better access for patients and families to be able to afford better food. So if you look at statistics, 1 in 6 children go to bed hungry every night, and over 10 million Americans are food insecure households, which means they're not getting their ends met from either income or financial constraints or any other problems too. So we have to do something of an effort to expand on that. So referral basis and so forth.
Right. Do they know that they're food insecure?
A lot of them are embarrassed or ashamed, as if it's taboo, and I think we need to break that feeling of that they can't approach us in order to expand and give them the help that they're looking for. So when they come to an office, or if you find them in another type of medical setting, it's good to screen them. And in order to make things much easier, because the physician is busy, the patient is busy about dealing with all other aspects of your medical health, you want to give something that's a reliable, viable, quick source. So a 2-questionnaire can be used as a food insecurity screening tool, and that opens up the avenue for a whole conversation.
Right, and that is talked about in this article in the American Academy of Pediatrics Journal, shown here on the screen. And this you encountered while you were doing your training, right? And it was sort of like an epiphany, I understand?
It was, because you would see so many children in a hospital setting or the office, and then when you know the statistics that 1 in 6 are going to bed hungry, and you can't sit there and look at a picture of children and be able to point out which one is the one that's going to be hungry. So when you see that, and it's sometimes the child needs an advocate, and it can't be the parent all the time because of feeling embarrassed or ashamed, then the physician needs to become that advocate for the pediatric patient. So doing the screening tool helps to identify which children during my rotation were at risk, and I figured, why not adapt this to the adult population, since over 10 million adults have food insecurity problems as well.
Really? Yes, and then this is across all walks of life?
All over.
Right. Why don't people know that they're eating poorly?
They may not realize it based on their cultural backgrounds or what the foods they had growing up, or they are aware and they just realize that they can't afford to go get the organic foods or the more nutritious vegetables and fruits, and only fast food is available to them because they need to work 3 jobs to make ends meet, and they don't have the time to cook or go to the supermarket and get better food.
I see. Now, what are the 2 questions?
So the first question is, in the past 12 months, the food I bought didn't last me until I had more money or couldn't have any money to buy more food. So, and these are self-directed questions you could do as a questionnaire. And the second question is, in the past 12 months, I worry that I don't have enough food to last me until I get more money.
Yeah.
And if the patient answers often true or sometimes true, then it's positive. So and if it's for either question. So the first question is more of saying that definitively I didn't have enough food to last me. And the second question is about worrying that you're not going to have enough food to last. And both of these are seen as being a high sensitivity, 97% sensitivity, which means 97% of people that answer true are indeed true positives and are at risk for food insecurity and hunger.
So, a patient, either a child or the parent would have to, of course, come with the child and
Right.
agree to letting the child speak about it, right?
True. Well, we have different ways. So if you're dealing with a pediatric patient, the children are more aware than we'd like them to think we know.
They really are.
They're little sponges. They know what's
Child
going
knows
on.
when you're lying to them.
This is true.
Yes, right.
So we try and, if we do the questionnaire, we give it more towards the parents and we discuss the results with the child outside of the room. If you're dealing with an adult, then you just deal with the questionnaire in the room.
So
during
you
your
actually interview the child individually without the parent present.
Right.
I see. And they go along with that?
They're usually more honest to the children,
Right.
so you get your answers.
And the parent goes along with it, I guess.
They do, because if you construct it in a manner where you're showing you're there to help and that you are legitimately concerned for their well-being, they're more likely to open up to you.
Do you ask patients, going on from there, how do you treat it? Do you go into further questioning? And what does that consist of?
So it's a screening tool, which means that you first identify the population at risk. And once you do that, then you could develop into more further questions. Like, why do you think you are not being able to have access? Oh, I can't get a ride. I don't have anyone to drive me. I don't drive. I don't have enough money. My job doesn't give me security. You find a whole slew of different answers, and I guess it depends on which answer comes about, then you can better help them which avenue. If it's more so of the money or the supplemental foods, then there are supplemental programs, like the SNAP, the Supplemental Nutrition Assistance Program.
And that's administered through whom?
That is for the government.
Government?
And then
County or?
they have local
Okay.
divisions, but it's still more of the full nation effort. And then WIC for the women, infant, and children that give also supplemental nutrition.
Say that again.
WIC,
WIC.
women, infant, and children.
It's women, infants, and children. Okay. Now, do you then try and devise a nutritional turnaround program?
So as physicians, our job is not necessarily always to have to fix the problem, but to find where we can give the appropriate resource. So if it's more of access, then maybe Meals on Wheels would be the best option, or hooking up the family with a local food bank. And that could be the solution. And you open up a whole team approach to the family that's at need, and then they are able to get the resource that they require.
I see. So where does actual nutrition guidelines and what you should eat as opposed to what you should not be eating now? Where does that factor come in? Do you bring in a nutritionist, or do you do it?
I do most of it myself.
I see.
Because I did train as obesity medicine and nutritional medicine specialist as well. And we go through a meal plan, but I also first find out what they are eating from day to day. And I say, okay, why do you choose this food item on this menu as opposed to this item? This one has a higher fat and content, and then this one has a more nutritional vitamins and minerals.
Well, I first say my nutritionist is my wife, who's always saying that's too fatty and that, and that's as far as it goes. But in all the years that I have gone and seen physicians, no one has ever talked about diet except, well, you have to lose weight. And so this is why you're on the program, because I think this is a fascinating avenue of inquiry to make people feel better without being invasive or whatever.
Right. So not everyone is as lucky as you to have your wife to do that for you.
I am so lucky. That's
good.
true. Right.
So, in terms of why physicians probably
Yeah.
don't, I think it's because hunger is invisible. You see a patient, and it could be a well-groomed, well-dressed person with a cell phone and a car, but meanwhile they have recent unemployment and they're not able to afford food, and they have probably minimal things at home.
Nervous, anxiety.
They
just
don't want to
doesn't
admit
show.
it, they feel ashamed, and we have to show that it's okay to bring these things forth, coming into the visit.
Yeah. So, what conditions, I assume chronic conditions, do you attempt to relate to nutrition deficiencies or excesses? What's the connection?
Well, I do a very thorough exam in the
Yes.
office, and based on just some physical findings, especially with your nails and your tongue, you could see a lot of vitamin and mineral deficiencies. With the pediatric group, if they're having developmental delay, are they not getting the right nutrition for their brain development? There's also mental health problems that can occur for lack of good nutrition in your body, and obesity. We think that obesity wouldn't be the one because it looks like excess calories, but it may not be excess good calorie. So I think when we have this obesity epidemic coming about, and other practitioners see a patient that's obese, they're assuming they have too much food and too much access, as opposed to being the opposite. And I think that skew-ity is probably what needs to be corrected.
I see. Now, tell us, what do you have different test protocols for different patient presentations?
Every patient that I see is on an individual basis. So my first visit with the patient is always a 1-hour consultation, because I go into really depth about your job, your living quarters, your nutrition status, your diet meal plan, your family matters, your stress level. Everything really does account. And I have patients of all different types of ethnic backgrounds, age groups, as well as medical conditions, from oncology patients with cancer, because obesity is a risk factor for cancer reoccurrence, as well as patients trying to better themselves for wound care. Good nutrition will help your wound heal better.
Yeah.
And just for patients just want to get healthier overall.
Right. So, physicians in the area are aware of your service?
They are. I'm getting more patients from outside of the New York-Presbyterian group that have a primary, and I see them just to help them with their, whether it's a weight problem or their nutritional status.
Yes. Do you feel the medical community is now becoming much more aware of nutrition's effect on health?
I think it definitely is, because since the food bank conference, I've had a lot more referrals of outside physicians, so I think it's going out into the area, which is great. But I want to take it a step further and have the whole physician community be more educated about it. Don't mind seeing every patient in Westchester, but I'm still just one person.
Yeah.
So I feel that my next step is to go out and reach out to them. And I'm going to be talking at grand rounds at the hospital with a whole bunch of physicians to show them the screening tool and say, hey, why don't you implement this too in your office?
How did you become so interested in nutrition as a field?
Initially, I just went through the training for
Yes.
family medicine, and it didn't dawn on me until I went through my rotations, where we heard about, and you can still see, the obesity epidemic that is occurring and growing still in America. And I thought, what would be the one thing as a single person that I could contribute to the most? And I thought it was to take care of one of the biggest growing problems in America.
Yeah. How fast can a nutritional turnaround in eating habits make a difference?
Some patients do very well when they are very proactive, and I have others that it's a slow and steady course, which is completely fine. For one patient, I'm very proud of him. We just celebrated the 1-year mark that he had lost 100 pounds.
That is really impressive. I mean, it's hard to lose 25 pounds, let
Yeah.
alone 100.
100 was, and what makes it even more special in this case is that he does have progressive multiple sclerosis, where he walks with a cane, and physical movement and activity is difficult for him. So doing more of nutritional changes was his biggest change that he did.
So, just out of curiosity, how can food make such a difference? I mean, you have to be mentally tough to change your eating habits, and that's what they are, habits.
It's true. So it takes 19 days of doing something continuously to change into a new habit.
19 days.
I tell them, give me 19 days of doing this, and they say, okay, I can give you 19 days, and that helps. A lot of it also is that they're not aware that the foods they're eating are not good for them. So it's more of the education aspect that's the best thing. And I teach them how to read a nutrition label. And when they learn, they're like, oh, and you can see like the eyes glow.
Yes, the best thing that was ever done for food in the last 30 is the nutritional information that the FDA required.
Right.
And even I look at it now, you know, comparing yogurts. But be that as it may, how is the, have you evaluated, is the patient kept on track with regular follow-ups?
Yes, I have some patients that we start out with doing weekly appointment, and then they go bi-weekly, and then once a month.
We're talking with Dr. Mona Kennedy, a family physician specialist at the New York-Presbyterian Hospital Westchester Medical Group. And if people are interested and a light bulb has gone on in their heads watching this program, whom should they call for information as to how to proceed to?
Well, they can, if they find that they want to discuss this with their longtime primary care physician, then they can bring that issue up to them. But if they don't have one, I'm more than happy to see them. So they can call New York Presbyterian at Lawrence Hospital at 914-787-1000, and they could ask for Dr. Mona Kennedy.
Yes. Is your approach to treating chronic disorders as nutrition-based becoming more accepted?
It is. I think now when we learn more about medical conditions, even cancer, cancer is an inflammatory disease, and if you show that you can give anti-inflammatory foods and treat food as good medicine to a patient, they think this is the best thing for them, because not everybody is going to be pro-medication and not happy about things like chemotherapy. But if you can tell them there is something you can do to help out your own case, they're all for it.
I see. So it's changing a turnaround from this is better than medicine,
Right?
Because it tastes good and is good for you, and it'll fight this. And everybody wants to fight cancer.
This is true. If you
Yes.
eat enough fiber, you
Great
can help
motivator.
prevent colon cancer.
Yes. Now, what has been the success rate of treating these chronic disorders?
Well, the more weight you lose, the bigger the benefit for your health, which
There
is
was a
true.
correlation between that?
There is. So even 16 pounds off can make a huge difference in your A1C, which is your diabetes level. So even a little bit can definitely go a long way. Only 5 to 10% of your body weight loss will make a huge impact in a beneficial way in your health.
And of course, your heart doesn't have to work as hard.
Exactly.
All right. So what is that diabetes level you spoke about?
The A1C level,
Yes, what is that?
it's the amount of sugar molecules that are attached to your red blood cells that are circulating throughout your body. And they change every 3 months that you want to do level change. And because they do circulate throughout the body, it affects your kidneys, it affects your eyes for glaucoma, it affects every organ in your body.
Really? I didn't know that. So that's why we have People to be Heard as a program, folks, because you will learn something on this program every time you watch it that you did not know.
Well, physician comes
Yes.
from the Greek word to teach.
To teach, that's true. Now, what conditions are treatable in part with nutrition adjustments?
I think every single medical condition can be treated or benefited from good nutrition.
Now, has there been any effort at really quantifying what to do nutritionally for each disease? In other words, just a chart look, if you have this, if you suffer
Right.
this, I recommend this, sort of like a general guideline. Anything like that?
There are some general guidelines. If you're a diabetic, you want a low carbohydrate diet. That will help with that. If you are having heart disease, you want a low sodium diet. So there are guidelines, but I think every person still has an individual case, and that's what I try and focus on when I see
I
patients.
see. So you can, as we spoke earlier, you can provide a real custom program. Now, how does is this covered by insurance? And
I have almost all insurances cover for
Yes.
it. There are some patients that prefer self-pay, and
Yes.
we offer discounts as well, but
So-
we try and help out everyone.
you know, so this is not like a $25,000 or $30,000 operation or
No,
something we're
this
talking
is
about
probably
here. No.
the cheapest thing you could do in terms of the cost of medications and the other like operations. You can prevent a heart attack if you do right nutrition as opposed to doing an operation.
I agree. Now, what do you want? Who do you want specialists to refer to you? Who can be helped most by your in-depth analysis?
Every patient with any medical disease can benefit from a consultation of good nutritional food and education. But mostly patients that are struggling to lose weight on their own and have been trying to do things the right way, they may need a different approach or a different re-education, and I can provide that. So anybody that felt they're stuck or struggling.
Based on, you know, how many years have you been doing this now?
This is my third year.
Third year. And, well, enthusiasm counts, right? Now, the elderly, the disabled, this is a growing population because of the boomer generation is not booming anymore. So, at any rate, what is nutrition being paid attention to with the elderly?
I pay attention to it to all my patients, and I want other providers to start thinking the same, because you'll find that that's the population that feel most embarrassed and don't want to bring it up. And since implementing the questionnaire into the office, I've had more Meals on Wheels referrals that I needed to make, and the patient feels so satisfied and relieved, and you wouldn't know until you ask.
Yeah.
So I have patients even as old as 95 that I do nutrition counseling.
And the nutrition that you recommend and the services you recommend have helped them relieve the nagging.
The elephant in the room.
That's right. And now, we come to the last part of the program. What are the major issues, especially in this area of the country, regarding nutrition and weight? What are you seeing most often that people have to pay attention to that they're not paying attention?
Well, one is looking at the nutrition labels like you started to do. That is very important. But I think our biggest problem in America is that a $2 fast food burger is more accessible and affordable than the $8 salad that's lettuce and tomato.
Or the $15 salad, as the case may be,
If you
which
want
is
just
way
piece of chicken.
overpriced, I might add. Right.
Exactly. And I think we need to reverse those numbers. We need to make more affordable food, whether it's helping out the farmers, changing the whole food industry. Something needs to give, because if it's not the food, it's going to be the people.
And from the actual conditions that you see today around this area, what needs to be addressed most, other than, of course, making people more aware of the hunger problem?
I think it's more of the referral basis. I think we need to get more of the community connected with the food banks.
Now, we are coming to the end of the program. What would you like to say to persons who perhaps are thinking, well, maybe I could change my habits, but it's going to be so much work or whatever? What would you say to that person?
Motivation is definitely something that needs to be a first step of anything. And I tell them that there are so many more resources that they're not aware of that we can help them. So I want them to know that they don't need to do this alone. It is a team approach. There is nothing to be ashamed of, and we can provide the help that they need, because good food helps your health more than just physically. It's mentally, it's developmental, everything. So if you want to be the best thing for your body that you could do, you want to have good nutrition.
Right. And if I think we should emphasize that you are working with people from all walks of life, from
Yes.
rich to the poor, and you are just not referring them to places where they can get food cheaply.
Right.
You are providing a whole person-centered program.
It's a whole approach. It's the mental health, the physical health, and then actually physically getting good food presented to them.
Is there any other example of how a patient has done a remarkable turnaround?
I see obesity medicine patients, and I did have a lady where she was struggling to lose weight for 3 months, and I was like, okay, what do you think is going on? I devised this meal plan for you with these food items and this exercise, and it came out that she's like, I can't afford the food. And that was a big shocker to me, and I thought, okay, this is where we need to take care of the problem first. And then after we did that and we devised a plan with the local food bank, the weight started to come off.
So once again, if you have a number you would like people to call for information about this, what is it?
914-787-1000.
Right, and they would be getting whom when they call?
They would ask for Dr. Mona Kennedy,
Yeah.
and I can see them in either of my 2 offices.
I see, in Eastchester and White Plains.
Correct.
Exactly. And but how many patients are you seeing, if I might be so bold to ask?
It's getting busy, which is a good thing,
Yeah.
and I see a good 16 or 20 a day.
15 or 20 a day. That's 100 a week. Well, people are paying more attention then.
They are.
That's right. So Dr. Mona Kennedy, our guest, from a family physician specialist from White Plains, some New York-Presbyterian Hospital, Westchester Medical Group. There, I got it.
It's a tongue twister.
Right. So at any rate, thank you. You have been heard. Right.
Thank you.
All right.